Hello, my name is Jared Bodine. I'm working with my group. We're Group 1 for Chapter 1, and we're dealing with Health Partners. So Health Partners is actually originated from Bloomington, Minnesota, and there's a couple things that we want to emphasize with these guys. These guys are the largest consumer-governed nonprofit healthcare organization in the U.S. They're actually quite famous for their transformative work in primary care. Especially in areas like diabetes and other chronic conditions. So this chapter that we are covering emphasizes some issues that they were presented with. These were kind of looking around. All around them, technology was in automobile industry, different industries, and kind of was lacking that scope to it. A change needed to happen to healthcare in general. They kind of thought from the old system. The old system kind of kept the doctor meeting with the man in charge, and he and action was as they visited there. And the patient, so they were kind of everything the doctor said. So obviously, and they did as well. On from that, they also found in standard doctors that they knew were treating patients on their own. A patient in a certain was treating him in a different way. Standardize that. And that health partners needed to be. They also want to get them involved. They wanted their boards of trustees and not just be these. And the last Partners Association really improved company whole system, build up system together. If they do this part to make it quicker and more effective, they also want interaction with the doctor. They also aspect of it, and best if we do that all at just one. Those costs. Another area could be thoughts where if we can do it, it'll be much.
Okay, Comby, I'm just going to give a little bit of problem as well. Health Partners, they just the normal care. They saw too much practice of medicine, not enough standardization. Students coming out of C learned how to practice and had to reinvent the wheel. That led to lots of in the way that they were practicing medicine. In 2001, Forrest, a clinician and CMO, read Quality Chasm, which was published by the and he read to Air Medicine, a report by physician Dr. Donald Berwick's Escape Fire. These inspired Boris Health Partners and changed the way. So Health Partners used the framework moving forward by incorporating into its mission.
We'll be talking about this. As Kyle's Chasm report came out, many of the doctors had also healthcare system to light that there's 100 deaths happening in hospitals every year. Chasm report laid out issues found in this healthcare to as called functioning more efficient healthcare system, and in order to find out which aspects of their current, so I think the goal is to find out which parts were to follow this chasm road to a more efficient healthcare system.
I'm Emily Allen. Some facts that should be considered a Health Partners case. So physicians aren't as a medical student. We think that they should all be thought of as their with some custom. This allowed become overwhelmed by the required. They had to stay after charting. They were generally unhappy with the quality of partners, put in the thought that they should standardize and then customize, exemplified by the care of patients. They saw healthcare points that result in greater quality, low hemoglobin A1, low LDL, low blood pressure, tobacco use, and point out that all physicians of care be customized or what would be customized for. There were programs that allowed customization to work. One was Diabetes Wizard, which was MR, and for patients to see what on it flagged point of care need, and it allowed physician was possible within the standardized. Health could only be used efficiently, so they worked really hard to ensure that physicians knew how it could best be utilized. Huge quantities of physician requires. They understand standardizing all of these shift, and most physicians, when standardizing patient visit, think that we should be to customize their healthcare. About this culture shift in hospital compact, there was a list of, and so for example, customized had to adhere to specific points of hospital. This and new doctors, rooms, or the hospital the culture shift with, and it would kind of doctors who had been there for years.
Dr. Chan, I'll be talking about alternatives that they had. So one alternative could have stuck to the bulk of a system and independently their own training and experience, be efficient, none of this stuff. There was care. And so one of the IHI pursuing program, they utilized and so in this, they conditions and then 5 conditions that they had at the hospital. Fortunately, this one at a time, so basically improved the quality of healthcare for maybe diabetes, but multiple conditions, so it wasn't a very conditions. The next alternative they had was the Wagner model that was much more. It essentially used community health delivery system design, medical information systems. So it was a much expensive model of health. Allowed was it fostered an informed patient option or alternative that they had, which was similar to the adaptation of the Wagner model was for. And in this model, during and after appointments, so payers would had to do for the patient clinic for the patient during the visit, and they would all patient after the visit. Healthcare model, patient-centered, and it allowed and overall standardization of care, and they is for customization for the individual patient to provide better healthcare.
To go over a couple of recommendations chapter, as primary care using especially for chronic conditions, they should work on more fully integrated EMR system so physicians they get done and patients can receive quality healthcare. Continuing to make improvements on their staff will also be vital to their success, and hiring physicians, physician culture of that